return to RXP International. This module will discuss with you pediatric psychopharmacology. I am Elaine Levine, and I have with me today my friend and colleague, Dr. Elaine Foster.
I hate to tell you this, but I don't believe in prescribing for children. I don't know if I should be here with you as a discussant because all you're going to hear is me say that I would never do this.
Well, that's exactly why I want you here. I'm a reluctant prescriber too, but I think it's very important to have you here to help us look at the range of why we might prescribe and why we might not want to prescribe.
But what if we don't ever want to prescribe?
Well, even then, if you're seeing adult clients, I think it's important that you have some understanding of what kind of behaviors their children might be demonstrating and how they might feel about that. And also, you will find as I go through this review this morning, parents are the key in so many cases to ameliorating children's distress and thereby limiting the amount of medication. So with that in mind, will you hang in there and see what you think about this presentation?
I'll hang in.
Okay, thank you. Okay, so let us begin. Well, Dr. Foster just raised the ante on the objectives today, but even so, we will try to provide an overview of psychopharmacology, and you'll learn quite a bit about factors that need to be considered before you use psychotropics with children. You will learn about medications that are being prescribed for particular syndromes. And very importantly, you will learn how few of these medications actually have FDA approval for use with children. And I'm sure you recall that by FDA approval, we mean the Food and Drug Administration, which determines whether or not a drug will be on the market for a particular population and a particular indication. Keep that in mind. It's important for you to remember. First of all, I want to begin by expressing to you that many of the thoughts in this program come from my personal experience and they're a synthesis of the research that I have done and my many, many years of work with children and families. So let me tell you a little bit about that background so that you have it as a way of deciding if you are comfortable with some of the conclusions that I am drawing. So remember, there's some overarching principles and ideas I'm mentioning in this presentation. They're really my ideas. They're based upon research and experience, but you can't necessarily go to a textbook and find them. So what do I mean by that? Well, way back when I began my study in psychology, I focused on child and family therapy. That was actually my internship site. I was placed in an inner city school environment, but back then the rigors of who would be your supervisor were not so stringent as today. So there wasn't really a supervisor on site. The supervisor was one of my professors at the university who had done a little bit of work with children. So I read everything that was available at that time, and we'll be talking more about the history of development of child psychotherapy and child psychopharmacology in just a few minutes. But here let me mention that I was very influenced by the humanistic tradition, which was quite significant and impactful at that time. Carl Rogers was writing and being quoted about how important unconditional positive regard is with the patient, and how if you project that regard, people have a capacity to heal themselves. And then there were others that postulated they had a more scientific approach, such as Kharkov and Truax, and they tried to identify what are the elements of a relationship that communicates this positive regard. One of the most influential books on child therapy at that time was a book by Virginia Axline called Dibs in Search of Self. Dibs in Search of Self. And fascinating book because she assumed a completely non-directive approach to working with children. She used toys and allowed these children to play, and all she would say is kind of a reiteration of their comments, or something as simplistic as, you want to play with the toy soldier. You want to put the toy soldier in the sand. And she indicated that they got better and better. So when I began working in this inner city environment, I knew to get a lot of toys and to try to listen to the children. They gave me a decrepit old classroom and said, do what you want here. And I scoured the school district for old toys and bought some, and I might mention here, toys in which children could project their thoughts and feelings. And I began my work listening to them and repeating what they said. And lo and behold, the teacher said, you're a wonderful child psychologist. So-and-so isn't causing any more trouble in the classroom. This is the first time little Johnny has smiled. I was flabbergasted, but very pleased. But over time, I began to feel uncomfortable with that straitjacket and put my own personality into it. And fortunately, there was a movement towards what they called existential child psychotherapy, with Clark Moustakas being one of the primary writers in that field. And he recognized that once you had a relationship with the child, it was very helpful to communicate with them about their thoughts and feelings, and to realize that they were little creatures that had views about life. And if you could find a way to access that on top of having a relationship, you could maximize your effectiveness with them. When I completed my doctorate, I worked in a counseling center for young adults, but I continued to do my research and exploration about child therapy. And then I moved to New Mexico, where I was an academic professor, but I did set up a part-time private practice, and again I specialized in child and family therapy. Along the line, concurrent with that, I wrote a textbook, Listen to Our Children, with Alvin Salee, in which I began to synthesize what I had learned about dealing with children in a mental health environment. And that textbook has had several editions, I'm pleased to say, was some of my initial efforts to synthesize some of the information I'm going to share with you today. So I began to expand my ideas regarding play therapy, and you see before you an outside play therapy environment that I dreamed up and a friend helped me build that we use even today. On one end, there's a puppet theater, and in the box are a lot of puppets where children can act out their different feelings and thoughts. There's a kitchen, a restaurant, and what I discovered over the years is little kids love to cook, and especially the boys, which is fascinating to me. Maybe it's because it's not an activity they're often allowed to do. And it's such a relationship builder. So I had to have a little restaurant in my outside play therapy area. There's a bank, and that required a lot of activity, so the children with hyperactivity loved the bank because they could click the cash register, they could tell me I was a bad customer, I didn't have enough money in my account. It was a lot of action. It really kept their attention. But probably the most powerful of all was the jail. I cannot tell you how many times I have been thrown into that jail and said, why am I in here? What did I do? What do I have to do to get out? And I learned about children who were upset with their parents for a variety of reasons, and I often learned about sexual and physical child abuse. As I continued my career, you know, I became very involved in the movement for prescriptive authority for psychologists. And I found that once I had my license, 0001, I love to say that, all sorts of people wanted my services. And I got called by a clinic right on the border of Mexico and the United States in a little town called Barino. And you will be learning much more about this if you haven't already, when you listen to our presentation on social justice. I was called in there to be the person prescribing the medications for patients. And this is where something that I read in the literature came so much alive for me. These were very poor children, underserved population, and I couldn't believe the amount of medication those children were on. So, Dr. Foster, you'll probably be a little bit relieved at this point to know that my goal there was to keep in mind something prescriptive authority psychologists say, that the right to prescribe is the right to take people off of these untoward side effects, medications causing them so much trouble.
Well, I hope that's what you did when you went to Barino.
Well, we'll leave that as an open question and ask the students to look at our video on social justice. Well, it might surprise you that this early in the presentation, we have a slide that says conclusions. But I have come up with some conclusions over my years of working with children, which you're going to see is going to color every slide that we look at when we go forward. So I could also say they're underlying assumptions. Let me get them out right now. First of all, I think it's very hard to diagnose psychological disorders in children. And in our other presentations, we've talked about medications for depression, medications for bipolar disorder, and we've emphasized how important it is to try to come up with a diagnosis. Well, I think that I can show you and explain to you why really formulating a diagnosis is so difficult. But let me remind you here that children's nervous system is not fully developed. And so and on top of that, the frontal lobes are not fully developed. That's where you remember, you develop your reasoning ability and your ability to control impulses. So when they react, their whole system reacts. in biologically, psychologically, and they have a range of ways that they can react, really. And I'm going to be telling you what I look at as those range of reactions in a few minutes. But I want you to know that I think many children are over-medicated. I've discussed that. And another factor, which I'm going to give you evidence for, data for, we really don't know the long-term effects of so many of these medications. So the conclusion for me is that they should not be used unless least intrusive interventions have been attempted. But I'm going to try to, as much as I can, synthesize for you what would be those interventions that you should consider before you even come to mind to think about calling a physician and saying maybe this patient should be on medication. What do you think, Dr. Foster?
Hear, hear. That's exactly what I would like to see, although I don't picture myself calling the physician and suggesting a medication.
Even then.
I don't know. I'm going to try to continue to listen because so far you've really gotten my attention. You seem to really care about these children that you work with.
Okay. That's a big part, and you surely want the children to know you care about them. As Dr. Foster said in another course on anxiety, relationship, relationship, relationship. Okay, you're going to find that I wanted to give you information that you can use for documentation. So I'm not going to go through all of this slide. This is a slide for your information and background. But what I want you to know is that there is a high level of disorder among children and adolescents. This has been shown over and over again in the research that up to 15% of children may have emotional and behavioral disorders that we later in life see were the source of their difficulties, and that maybe 1 in 5 of those children have received any mental health intervention. So while I'm talking about the limitations of medication, I'm not in any way suggesting that these children, just leave them alone. These children don't need help. So I mentioned to you the difficulty of diagnosing childhood disorders. Why is this? I mentioned a couple factors, but keep in mind their limited language. So when you say to a child, "Why did you do that?" their ability to tell you why, they usually can't. On top of that, we mentioned the developed frontal lobe development. They may not only have the words for it, but they, on top of that, may not really have the intellectual ability to understand what led them to a particular behavior. Even so, you're going to find that very much of what is considered a diagnosis in children is just someone observing their behavior. So a teacher says a child is obstreperous at school, therefore he must have ADHD. Or a scout leader says this child won't relate to anybody else, maybe you ought to think they have an anxiety disorder. So we're depending upon some rather gross behaviors when, most of the time, when these diagnoses are made. And so I also want you to think, and I'll repeat this idea a number of times because it, to me, has been very important in my practice. Because of the way they respond in a global, gross manner, a behavior could represent so many different underlying distresses. You could have a withdrawn child who underneath there's an attachment issue, or they've been through terrible trauma, or they could have ADHD without any hyperactivity and they just can't even focus. They could have grief over the loss of a pet or a parent, or just temperament traits that lead them to be quieter. And they could have physical illnesses early in life, and this can have enormous effects upon their behavior. So, when you use our psychobiosocial framework, rather than trying to jump to a diagnosis, we know that there are a number of factors we need to look at in a child's life before we try to formulate a diagnosis on the basis of their behavior. First, we want to have a very extensive medical history, and if we don't have it, to be sure we get a medical exam of the child. We need an extensive family history, and by that I mean if you can go back several generations, all the better, because we do know that some illnesses, mental illnesses, have a high inheritability, and so it might give us a hunch of which way to be looking. But certainly you want an extensive history of the family that you are dealing with. It's important to carefully trace the origins and the development of the behavior of concern. When did it start? What was going on in the child's life at that time? What was going on in your life as a parent at that time? Always obtain a clear understanding of the family dynamics, and in most cases, this involves seeing the family with the child. You want to know if that family looks like it's functioning well, in which case you might wonder if there were external forces, trauma, or genetic factors contributing to the difficulties, or if the family seems highly dysfunctional, you know that's going to have to be a first line of intervention. Importantly, you need to have a clear understanding of how the child functions in various environments. If the child only misbehaves in one environment, and I know you say, Dr. Foster, you don't know about children, but what would that tell you? If they only misbehave at school or only misbehave at home?
Well, of course, I'd wonder, is there some teacher that they don't get along with? Might they be bullied at home? Is there some dynamic between a parent and the child that's causing them to misbehave just in that one setting?
Of course. So, even though you're not a child psychologist, you, like Dr. Foster, can help a lot by keeping this kind of factor in mind. If you often hear, this child is misbehaving at school, they must have ADHD, but they don't misbehave at home, they aren't a problem at home, I doubt that it's ADHD. If it really is a biologically based attention deficit disorder, you're going to see it everywhere. And likewise, if the parents are telling you that this child is misbehaving, or let's say it's a family in divorce, and one parent says they're perfectly well behaved, and another says, oh no, they're in big trouble. I think they must have an anxiety disorder, or is my child antisocial? You know that there's some situational factors you need to look at first. So, see this little girl? Something's not okay, but what is it? I don't know. She actually might even be laughing. She could be embarrassed. She could be humiliated. Is she withdrawn? Is she about ready to explode? So hard to tell. So what I have come to realize is that you can't necessarily note by looking at the child, even talking to the child in a session, asking for the observable behaviors, we need to find out what's at the bottom of the problem. And if you don't want to just run to diagnosis, you may wonder, well, how am I going to organize this information? Here's the way I've begun to do it over the years. I see children's disorders as falling into three primary categories: disorders of attachment, fight-flight disorders, and more biologically based disorders. I'm going to talk to you about each one of those, the means of intervention for each one of those that from a psychobiosocial model would be first line, and then we'll look at whether or not there might be a role for psychotropics with those disorders. I'd like to discuss what I call the term attachment disorders is well known, but as I'm using it here, a global concept for looking at a whole variety of children's problems. Attachment disorders could include underattachment, where the child gets tactily defensive when you even get close to them. It could be more manifest as an insecure attachment with erratic behavior, frequent testing, attention-getting behavior, lashing out, or it could be what comes to mind when we initially think of attachment disorders: clinging. Now, what are some of the causes for this? Well, we know that sometimes a medication that a mother takes while pregnant can cause certain problems in the child that could lead to an attachment disorder. But it could also be that the mother herself has a severe depression, a postpartum depression. And we know when a mother is withdrawn, I'm sure you know about this, that it can interfere with the child's ability to make contact with that parent and form an attachment. But also we know that an unreliable relationship with the parent, or one in which a parent has got significant problems and the child begins more or less taking care of the parent, can also lead to very serious attachment disorders. One of my favorite books in that regard is a book by Alice Miller, who was an ego analyst writing in the 30s and 40s, called Prisoners of Childhood: The Drama in Search of Self. And I love the subtitle of that, as she talks about how these children who are very smart tune into what their parents need and end up taking care of their parents. And that might involve a school phobia, where they can't go to school because they feel they have to stay home and take care of their mother. Now, I also want to mention this concept of early trauma. This can definitely cause attachment disorders in children, and many factors that we wouldn't necessarily consider a trauma to an adult can be quite traumatic to a child. So let me just mention here, I'd like to mention along the line some of the children that have profoundly affected me in the heart, in which there were some very complicating factors in which treatment individuals didn't really see the underlying attachment disorder. I'd like to tell you about a little boy, I'll just call him Benny for the sake of our discussion, who was very shy. I saw him in play therapy for the first few years of his life. And we used all sorts of techniques that I'll tell you about later to try to encourage his autonomy. And he got somewhat better, though he was still very attached to his mother, who was quite overprotective of him. Well, the mother the family got divorced and the mother moved away. So I lost contact with this family for a number of years. And in the interim time period, the little child went off to elementary school. The mother got remarried and she had 2 younger children. Well, his behavior went from being clinging to absolutely obstreperous at school. I learned this later when the mother called me for a telephone conference. He started cursing at teachers with words that his mother never even knew he knew. He absolutely wouldn't tolerate any intervention by his new stepfather. And as matters escalated, he got more and more violent. And at one point, right before the mother called me, he threatened to kill one of the younger siblings. Now, during this time, where mental health practitioners had not seen him in that very shy stage, that close over involvement with his mother, they were making all sorts of diagnoses about his disorder. And by the time the mother called me, and he was all of 8 years old, are you ready for this? He was on an antidepressant, a mood stabilizer. He was on trazodone, which has no indication for children at all, in the literature for FDA, because they said he wasn't sleeping, and on an antipsychotic medication. He was labeled as autistic, borderline, bipolar, with significant depression. It took a lot of work with the mother, and finally we got him to a hospital that had much more sophisticated help for working with children. And thank goodness, with our consultation and all, they took him off all the medication. And what do you think that they saw? A very shy child who had felt he had lost his mother first through having to go to school, and then through the marriage, and then through these younger siblings who he really loved. And increasingly, his behavior became more and more bizarre because he didn't know how to express that. And I might even add, at the end, he even said to his mother, "Please put me in a hospital, Mom. I don't know what's happening." So thank goodness we did get that way, get him there. And eventually, with the kind of therapy we'll be talking about in a few minutes, just a few minutes, he got a lot better.
Elaine, one thing that I think about in listening to this case is just how angry I feel when I see a child over-medicated. And it just brought to mind the idea, with you knowing about trazodone and there not being an indication, I'm starting to think that maybe the knowledge of these medicines will help any one of us say, there's no indication for this in a child, and fill in the blank of whatever else you know about this child, to help do what we do best, which is to unprescribe when, or at least recommend that a child not be prescribed to when it's not indicated.
Okay, in your comment, I'm kind of getting ahead of myself here. We will have a whole slide on using these medications as physical restraints. When I obtained a history from this mother before we got this young man into a hospital, she talked about how this medication had worked for a few days and stopped working. Then this medication had worked for a few days and stopped working. And I think what was really going on is he was being sedated, and then by just the fury of his little intensity and needs, he'd overcome the sedation. There wasn't really anything helpful being done with those medications. And she said that he slept with the trazodone. Well, of course, it's a sedating antidepressant that's not used very often for adults. But in time, he found a way to overcome it because his needs were not being met. So, disorders of attachment, of course, before we go on, you know that abuse and neglect can clearly lead to disorders of attachment also. Okay, we talked about attachment disorders. Now I'm going to talk about fight-flight disorders. And then lastly, we'll talk about disorders that seem to be biologically based. I'm just giving you an overview now. And we're going to come back to these three categories when we look at treatment, both from a psychological and a medication management viewpoint. So let me talk about fight-flight. You remember, I'm sure, what we've studied about the parasympathetic and the sympathetic nervous system and how those two nervous systems help us respond. You see a lion and you're either going to decide you have the wits to fight it or you're going to run. Make one of those kind of choices. Well, with children, very much in the world is like a lion. They don't have the ability to discriminate how severe the threat is, and so they're likely to respond in a very gross way, mind and body, with either fight or flight. Now again, a whole lot of psychological, social factors can cause a fight or flight reaction. Just like a lot of factors can cause attachment disorders. It could be abuse, it could be early illness, it could be being affected by a sibling who is very disturbed. Bullying, and I'm going to talk more about bullying because we are beginning to realize how significant this is in developing flight-fight reactions. Actually, it could be temperament traits, or it might even be something that the parents have modeled. So just briefly, to mention a couple examples, I once saw a child who had developed such a severe reaction to insects that it started limiting everything he did in his life. It became a severe phobia. And when I asked the parents to explain to me what were the origins of this, they couldn't understand it. They couldn't figure it out. Neither one of them had any fears about bugs. They talked to the kids about bugs are animals too. Finally, in therapy one time, this child said that he had a teacher, mind you, that was so freaked out about spiders that when she saw one in class one day, she actually passed out. They had to get school personnel there. And it was a beginning of a phobic response for him that over time generalized, where he withdrew from more and more activities and things where there might be a bug present. So that's just an example. How about another example? I once saw a child, a beautiful child, who had elective mutism. Now, this is, I think you'll probably know, a child who chooses in some environments not to talk at all. And this young child was very verbal with her siblings, but she wouldn't talk to her parents, and she wouldn't talk at school. So all the communication had to come through her siblings, and you can imagine what kind of dysfunction that caused in the family. Well, I worked with her in a variety of ways that we'll be talking about in some time, but over time, we finally got to the roots of it, I believe. She had a very serious illness when she was only 2 years old, and she was separated from her parents, and all these needles were in her and oxygen, and the parents do remember her being very frightened. I think she developed a generalized fear of adults. Now, this was very tricky because she didn't know it. I think it was in there kind of subconsciously. So we had to use other techniques to help her get comfortable with adults. But you know that in time we were even able to help her see that, how that experience might have affected her, and to use some cognitive restructuring techniques to help her overcome this flight reaction of, uh, of this limited speech and become more trusting of adults. So flight disorders. Now, I've mentioned bullying, and this is a slide for you to keep as a reference because it gives a lot of data about how destructive, how in a child's life bullying can be. They are likely, if you look at this, to much more have problems as adults, poor self-esteem. If they're both bullied and a bullier, there's a high correlation with antisocial behavior. So the effects of bullying are extreme. Now, this might look at first to you like a kind of typical scene between siblings. But I have learned over the years that what children consider very threatening may not be exactly the same as what the adult considers threatening. I had a little girl I saw in therapy, and her brother was always very spiteful to her. And he kept threatening to cut off her pigtails. And everybody loved her long hair. And he might as well, to her, have been saying, I'm going to cut your neck off. It was so frightening to her. So please don't underestimate what might be frightening to a young child. Sometimes parents are culpable in this respect. They think they're helping a child, but they'll say something like, you're going to get in that swimming pool because once you're in it, you'll like it whether you think so or not. Well, if it's too traumatic, it's an adult in forcing them to do something totally against their will, it can have rather serious psychological ramifications. Similarly, with children who do develop phobias, there's nothing dangerous about that spider. I want you to touch that spider. You might think that's well. How important is that? With some children, maybe it won't cause trauma, but with others, it can have extreme effects. The third category we're going to be looking at again is the biologically based disorders that have functional consequences. And these, again, we'll see it manifest either as a lot of activity or a lack of activity. We have genetic disorders. We have disorders like schizophrenia and bipolar that have a high degree of inheritability, and some like depressive tendencies that have moderate inheritability. We've mentioned already that there can be environmental processes that occur during the mother's pregnancy or in childhood, such as eating lead, paint, that can have disastrous consequences on intellectual functioning and psychological functioning. And there can be complications in the birth process, and as well as temperament traits. Now, I'm sure you can think of many other examples here too. So we've overviewed these groups of disorders as I see them. Next, we want to talk about the integration of psychotherapy and medication management with children and adolescents. First, let's get an overview about the origins of mental health treatment with children. I'm sure you know that our field of psychology burgeoned significantly with the work of Freud right around the turn of the century. But it might be interesting for you to know that work with children really didn't begin to evolve until about the 1930s. An early person to be concerned about children and their welfare was Sigmund Freud's daughter, Anna Freud. She conducted a number of experiments with children during World War I and II that had been separated from their parents. And she discovered that they exhibited this syndrome, failure to thrive, even though they were being physically cared for. So you hear there's the origins of recognizing the importance of the attachment to the parents. And her work with children mainly was analyzing them and analyzing the parents, especially the mother, and working with the mother to change the psychodynamics. So she did spend some time with children too. But actually, Leo Kanner, in the 1930s, an MD, became what is called the father of child psychiatry, because he established the first clinic in a hospital setting where the behaviors of children were looked at and considered unique from the behaviors of adults. That work set the stage for more individual assessment and work with children, which was originally very psychoanalytic and psychodynamic in orientation, involved working with the parents a lot to solve their problems and change how they dealt primarily with the children around the Freudian issues of eating and toilet training and individuation. Then, in the 1950s, we have the burgeoning of a humanistic thought, which I mentioned to you earlier, certainly influenced me, and books like we talked about, Virginia Axline and Dibbs' In Search of Self. That was followed in the 1960s and 1970s by quite a conflict in the field of child therapy. You had a group of people, like myself, like Virginia Axline, saying, relate to the child. I've seen that this really makes a difference. At the same time, there was a burgeoning of research by Skinner, B.F. Skinner, and his students, that you could identify discrete behaviors, and that's all you needed to do. Identify the inappropriate behavior and reinforce appropriate behavior. Now, I would suggest to you this approach really, the skewing got really extreme for a while. Maybe from people who felt like all you have to do is be there with the child, to people like Lovas at the University of California, Los Angeles, who actually shocked autistic children because he said, I can extinguish these difficult behaviors, and that's all that counts. But already, if you think about this in terms of the model I'm presenting about attachment and the withdrawal and aggression, what could possibly, the other ramifications of that must have been enormous. Fortunately, people are not doing that anymore, but I would ask you to think in your country, especially in areas which are underserved, are very punitive techniques still being used to try to modify children's behaviors? and what might be the consequences of it. Well, fortunately, we've moved past that in the Western world. Uh, we had a strong movement of systems theory and family theory in the 1970s, which I think is invaluable whenever you're working with a child and the family. And then gradually, a more constructive integration of the behavioral approach and the cognitive approach with the development of evidence-based treatments for children, particularly CBT, cognitive behavioral therapy for children, in the 2000s.
This is interesting to me, Elaine, because you said that we've moved beyond that in the Western world. And it reminds me of when I was stationed in Mississippi and was asked to sign permission for paddling of my child, which I think speaking about culture and mores, it really brings us back to that space. Is it always wrong to use these more aversive techniques with children? Because if we say that it is, we're going to butt up against some cultural norms that may be working for some people. So I'm not sure what you think about that, but it really makes my mind spin as you talk about it.
And I wonder what our students think about that. It's a very thoughtful question, Dr. Foster. I'll have to give that further consideration. It's also subjective. Suppose a child sees a lot of physical things in their environment, then maybe a SWAT wouldn't be so traumatic. You need to know so much about an individual child, and in order to know exactly how they're going to interpret these things that we adults do to them.
And I guess it really comes down to the idea that one size doesn't fit all, one paddle doesn't fit all.
Right.
And you're really speaking to this idea of individualizing and understanding that particular child.
Right. You could have a child who's like an easy child that rolls with the punches, giggles about just about anything, and was easy to raise, slept through the night, and you could do something pretty harsh and they'd, oh well, and then pick up and play again in a couple hours. You can take a sensitive child, and that can be as traumatic as Loveless, putting these kids into these electrical grids. And I would suggest that most of the kids he treated were very sensitive too, these autistic children, hypersensitive.
Good point.
Now, I'd like you to juxtapose what we just thought about, studied the evolution of child psychotherapy with what's been going on in the field in child psychopharmacology. I know there's a lot of information on this page, and just so that you realize the efforts put into this, Dr. Foster had to help me get rid of about 2/3 more, because there are events that seem so important to me as a child psychologist. But let's begin. In as early as 1937, Charles Bradley identified what he called minimal brain dysfunction and started using amphetamines to treat them. So right about the same time people were recognizing children needed help, there was the introduction of medicine. But from that time till almost 1990, almost 2000, the medications that were being used really had never been tested on children. What would happen is somebody would think this medication helped an adult with this disorder, and they would try it with children, and if they determined the appropriate dosage for children, it could get an FDA approval for children, even though it had never been used in a controlled study to see if it was efficacious with children. So when you look at a chart that I included for you I want you to keep in mind that a lot of the medications that have FDA approval for children were really medications like seizure medications and that came on the market in 1950s, and the first generation of antipsychotics. They have never been tested to this day to any extensive degree in standardized tests, standardized controlled studies with children. The companies producing these drugs are not motivated to go back and do those studies because they already have the FDA approval. So, matters did begin to change some in the 1990s with the development of the SSRIs. You'll notice that fluoxetine was used successfully and fluvoxetine with obsessive compulsive disorder, but it became well used before the first controlled studies. Around 2000, Hillary Clinton in our country formulated a committee to look at childhood disorders, and they began to identify this 15% of children that needed help and how many of the medications had not been studied with children. And so they pushed the FDA to ensure that there had to be controlled double-blind studies before newer medications could come on the market. Well, that sounds like that's a relief, so I don't have to worry about those later medications. There's been controlled studies. And I'd say, no. And the last factor there, poor Joseph Biederman, I'm pulling him out here for execution, but I wanted to stress at the end of this tape, so many of those studies were done by psychiatrists being paid high amounts of money. They were, as we say, in bed with the drug companies. That to say these were really randomized studies is a far stretch. It's only really been since about 2008 that looking at both the studies that where there were no effects as well as those with effects have been considered in recommending medications for children. This is a very new field. Look what happened from 1995 to 2003. This, gets back to a question you asked me, Dr. Foster, the other day. Why was it so much worse from 95 to 2003 and then seemed to level off some? Look what happened in terms of the prescribing of these atypical antipsychotics in the Western world. They tripled, and then sixfold. And Dr. Foster asked me yesterday, well, what happened afterwards? Well, I think, now that I look at it, this relationship between those doing the experimental studies and the being paid by big pharma might explain why this trend began to even out after that. But it didn't go down, you understand. It still stayed the sixfold increase. Many of these drugs are being used off-label without substantial research. All it would take is a couple studies by somebody famous, and they would be used for the treatment of children. So maybe you're saying, okay, you convinced me. But if they're controlled studies after 2003 and we think that they're legitimate, can we use them and feel comfortable about it? What do you think, Dr. Foster?
Personally, or, well, I would say no, because unless there's something very dramatic happening with that child, I want to do what you're doing. Understand that specific child and why they're showing those symptoms. I'm going to assume that they are normal until proven otherwise.
Good. And on top of that, if as you become a more critical analyzer of that research, you'll see that they may be controlled studies, but they're very limited. They're short term. There are few studies that have looked at how you do treatment over time. Very few studies. Very few studies look at comorbid conditions. And even fewer studies that have really been done in practice settings are done in labs. So the relevance of these medications, once the children are back in their home environment, is really not known.
It makes you wonder how long they're going to have to keep taking them, too.
Well, I have a slide on that.
Okay.
I just hope with all this information, I have given you a lot of data to advocate for your child that you're seeing in therapy to not use these medications as a physical restraint. Many medications can do that. The bipolar medications, the antipsychotics, blood pressure medications. I'm not saying that would never be useful, but recognize that when they're being used, it doesn't in any way reaffirm the diagnosis. It's just a physical restraint. Now, I have done some research comparing the prescribing rate in the United States to European countries, and there is a very significant difference. Initially, the prescribing was very consistent in the United States and England and in Canada. But I would say that the British and the Canadians are ahead of us in recognizing the possible dangers of over-medicating, and they have decreased the amount of medications used much more than Americans. But many Western, European countries, seem to never have bought into this concept of medicating children the way we have in the United States. I would be very interested in knowing what's happening in your country. So please put this program on pause and go to www.rxpinternational.org and click on the forum page. Let us know what's happening regarding the prescribing of psychotropics in your country. This is such a new field that if we work together, I think that there probably is very valuable information we can accrue.
And what I'd like to challenge you to do is to give us your thoughts, especially pertaining to any cultural values that you may come from. So, for example, when I lived in Mississippi, I think the principal of the school would probably say something like, I would rather give a child the swift paddle than to see them on some medicine that they don't need to be taking. And if that's going to modify their behavior, why give them something every single day when I can take care of it with one little paddle? And so I guess we want to hear your thoughts about that, especially coming from your cultural orientation, because you may teach us something that we haven't considered as we're going through our paces in our studies.
And to that, I would say, ouch.
I think the child would say that too.
You know, I'm not happy with either one of those alternatives unless a lot of other ideas have been tried. Now, the next few slides are for your reference. I want you to see the list of medications that have FDA approval now for children and adolescents. But with the background you have, I think you're going to be able to see much more carefully that many of them, like the mood stabilizers and the old antipsychotics, they may have an indication, but it's not coming from standardized controlled studies. And you'll also see how many, at least within our country, are being used off-label, that since 2000 they haven't been able to get appropriate studies that indicate they're in any way efficacious with children.
Okay, so maybe you are saying, okay, I get it. Are you going to just talk about the medications, Dr. Levine? Not yet. I just want to remind you that before you think about it, even though you now know the limits of the studies, so you're going to do this thorough analysis. You're going to remember how they function and look at their functioning in different environments. You're going to try to make interventions with the parents and teachers because that's part of the psychobiosocial model. You're going to try therapy techniques like play therapy and CBT, and almost always family intervention. And if there's very destructive family interactions, it's important to try to get individual therapy for the parents that are having these concerns. And you need some way of measuring gain. How will you know if the medication works or not unless you have some objective measures? There are a lot of ways to do that. One is to ask the child. There are questionnaires for children that you can respond to. You can ask the teacher, but remember you're going to get behaviors described there, but that can be helpful, and ask the parent. And most of the times it is important to have these evaluations from these three different sources.
Elaine, just a question that made me wonder as you're describing this, what would you do in a case of a parent who just wants the medication and maybe is dysfunctional, but doesn't want to address their issue? They just want to modify the child's behavior. Have you taken any position with those kinds of?
I think, again, Dr. Foster, it's very individual, but I just don't do that. I try to, that's why I put in educate them. I'm going to talk about the effects and side effects of these medications and that we need to try less intrusive interventions first.
And how do they seem to react to that?
Well, again, the relationship is so important. If you have a relationship with the parents, if you're compassionate about what they're going through, you realize it's a significant problem and support them, I haven't had any trouble getting them to respond.
That's good to know.
Here's some general factors that you need to consider if you're going to prescribe for young adolescents. And this presentation really isn't covering older adolescents, age 17, 18, when all sorts of different processes happen. So up to, let's say, or through age 16, you need to remember that adolescents are very rapid metabolizers. So they may need more medication than adults. Don't forget the girls can get pregnant. It's really important to consider that. And they can get pregnant at age 11 and 12 and 13. There's a lot of research about suicidal ideation using the SSRIs. And we do know that adolescents and children are at higher risk to those having suicidal ideations with SSRIs. You have the problem of street drugs with your young adolescents. So please, you need to consider when you're prescribing a medication that it may be interacting with something else, which limits its effectiveness or exacerbates side effects. And then with this population, there are rather extreme compliance issues. So trying to get them to use a medication if they don't want to, This gets back to Dr. Foster's point. The parents want them to, but they don't want to. It's like it's a destructive attempt before you even get started.
Should we recommend that they start at higher levels of medication because they are rapid metabolizers at that age?
My experience has been that you start at the recommended dosage, not necessarily a lower dosage, unless you have a particularly anxious patient. And you explain to them, the adolescents and the parents, that teenagers burn through things fast and we might need to go up on the dosage.
So pretty much still start at the normal dose and then take it up as you need to.
Right.
All right. So now you're saying, are you just like Dr. Foster? You're never going to use these medications? No, there are few circumstances in which I think once you have all these ideas in mind that they can be very useful. I think they should be school age. I'm going to show you some literature, or the lack of literature about prescribing with preschool children. If they are immediate harm to themselves or others, and you've tried less intrusive means, that might be a reason to consider psychotropic intervention. Now, if the child is exhibiting behaviors that are creating a terrible, vicious cycle, sometimes I think it's worth considering medication. By that I mean a child with attention deficit disorder whose behavior is so out of control that they are constantly being remanded by the teachers, being kicked out of school, their parents are angry with them, and you see they're developing all sorts of secondary problems because of this behavior. But again, you've tried other ways to manage it, and they've not been successful. Overall, then, I'm clearly saying that you shouldn't consider psychotropics with mild behavioral and emotional disorders with young children and young adolescents. Yes, I'm ready. I'm ready to talk to you about the integration of the medication with these childhood conditions. Hold on, Dr. Foster. We're going to talk about the attachment disorders, first of all. And you remember they can be expressed in so many different ways. Elective mutism, enuresis, bedwetting, encopresis, night terror disorders. I'm sure you can think of others. Let's look again at attachment disorders from a psychobiosocial perspective. I would recommend to you that if a disorder appears primarily to be an attachment disorder, then child therapy, education, and family interventions are the mode of treatment, not psychopharmacology. Now I think you had a question about this, Dr. Foster?
My question was, when you say attachment disorder, are you describing their attachment to their parents only, or could it include other attachments like social attachments, sibling attachments?
I'm so glad you asked that question. Those of us that have studied a lot in this field, I guess we assume what that term means, and I know some of you don't see children. By this, I really mean the attachment, the bond that formed with the primary caretakers. The primary caretakers. That's not to say that there won't be attachment disorders with others, but they're, we believe, a manifestation of early instability in the primary attachment. Does that answer the question?
That helps.
Okay. So what are you going to do then? Well, if you're a child therapist, I know you have many ideas related to your individual clients. Let's just talk about a few. You know always you're going to try to figure out, is this about fear of attachment? And then you're going to address the family systems issues if they're still going on. You're going to use your relationship and good understanding of behavioral management. So, for example, in the clinging child, you gradually teach them some autonomy. Those of you that do play therapy can probably identify with the case I'm going to describe to you briefly of a little girl, Sarah Lee, that I saw that was so attached to her mother that she wouldn't even come into the playroom with her mother. She knew, had a sense something was up. So I had to start by building a relationship with her and the mother in the waiting room. And gradually, we use that as, let's see if we can go into the playroom with Mom. Reinforce that. And then, let's go make a secret present for Mom in the playroom and bring it out to her. That didn't work for a few sessions, but I'm sure you understand what I'm saying about building autonomy through your language, through the way you relate to the child. For the child that is unattached, we have to work the other way. We have to find a way to build an attachment by attracting them with fascinating things that they might love. So it's very individual, but to work on evening that out, and then first with you as the therapist, and then, as Dr. Foster's saying, take a look at all their other attachments. You may have to work on those, but actually, once they get a stable relationship with you and the parent, oftentimes the gains will generalize to other environments. Okay, I would say, for me, at least for me, I don't use medication with the disorders that look like they're attachment disorders. The only time I would even consider it is if the child had that kind of disorder, but we kind of obviated it. That was under control. And now we can see there's a secondary diagnosis. We have a child that has trauma, or a child with that's uncontrollable, a very sensitive temperament child. Maybe if there's a secondary condition, that's what we're getting to next. Okay, so let's move on to the second category, the fight-flight reactions. And I'm going to divide this up a little bit in looking at the fight end and then the flight end. But remember, underneath could be the same thing, that same social situation, same temperament traits that get expressed either way. What are some of the first line interventions when we have a child that's overly aggressive? I think we want to always see if we can figure out the cause. Has this child been bullied and therefore they're becoming a bully? Is this a child like the one I told you about earlier who was so anxious and had an attachment disorder and was acting out anxiety, anything to do to get attention? Are we seeing the effects of drugs? Is this a family in trouble? This is what we need to look at first. And if we determine there are causes that we could try to ameliorate, that's what we should try to do first. Now, how do we do that? Well, there's so many ways, but individual and family therapy are clearly critical. With younger children, there's some specific techniques. Those of you that are child therapists probably know about them. For example, a child that's hitting, you can just hold them talk to them, I'm going to hold you until you can get your own control over these feelings. We really want to see if there's, as I've talked about, one of these vicious cycles going on where they have some problems and they're getting so much negative feedback from their peers or parents or teachers that that's what's exacerbating the aggressive behavior. And of course, thank goodness, now we have some very good CBT programs for anger management. For me, there are some children that become so aggressive and for whom all these other interventions haven't worked, that it may be worthwhile to consider a small amount of the psychotropic. For example, what comes to mind was a child about age 5 that had been having severe tantrums since age 3. His mother had had a serious depressive episode and was pretty fragile, and she was not able to manage his behavior well at all. I worked with the child in play therapy. I worked with the family. I made sure that the mother was getting some individual help. And while some of his problems got better, he was so miserable. He talked about having alligators inside himself that were eating one another up. And it almost seemed, what would you say, like hallucinatory in a way. It was so vivid. But I'm, again, not saying you should diagnose schizophrenia in a child like that, but it was very severe. Well, we continued trying all these methods, and once I got a critical call from the school, the teacher had been trying all the techniques that we discussed, and she was hoping that some of his acting out behavior would go on extinction. So she ignored him in class, and he just got more and more aggressive, to the point that she felt like she had to make the other children exit the classroom. And by the time I got there, he was in the classroom by himself. He had torn it apart. He had defecated in the wastebasket, and his rage continued for several hours. This was a child for whom it seemed like some kind of medication intervention could be helpful. We used risperidone, Risperdal, with this youngster. It is the only medication that has FDA approval for treating aggression and rage in children and adolescents. Now, there are a lot of other drugs that are being used off-label for childhood aggression. Mood stabilizers, other atypical antipsychotics, even psychostimulants sometimes, antidepressants, and blood pressure medications. You may say, why the psychostimulants? Well, sometimes if you can just get a child with severe ADHD and a rage disorder to be able to focus better on an activity, they're able to get a little bit better control of their rage. And you might say, well, why these blood pressure medications? I would say to you that probably it falls a bit within the category of using it as a restraint. It's just going to slow down their overall functioning. But sometimes in these very severe cases, I think it may be recommended. I can think of other severe cases, I'm sure you can. There are children that threaten their parents. There are children that really hurt the siblings, that carry knives to school. And again, I think you should try other interventions first. But if they're in imminent danger to themselves or others, perhaps the use of psychotropic medications is indicated. Now, I mentioned to you that at least within our country, many medications are used off-label for managing rage in children. Because remember, the only one with a Food and Drug Administration approval is risperidone. But you're going to find that many children are put on mood stabilizers, and many other atypical antipsychotics have been used. There are some studies that have, and these are controlled studies, that have evidenced effectiveness with these populations. And for the most part, as we've talked about before, the FDA is not willing to go back and consider whether or not to give them a formal FDA approval, and the drug companies aren't willing to go back and ask for it because it's so expensive. But at times when the risperidone has not been effective, it probably is worth considering some of these medications that are used off-label for rage. So what is being used? The atypicals, not just risperidone, anticonvulsants, stimulants, SSRIs, the non-stimulants, but non-stimulant ADHD medications. But with so little research, again, they should be used with intractable cases. This is a good point for me to mention that there are probably two developmental stages that are very important to keep in mind when thinking about psychotropics for children. Preschool children have a very different physiology than elementary school children. And the young teenagers, again, are quite physiologically different than the elementary or the preschool children. So I want to talk a little bit about what the research says in using medications to control rage in toddlers and infants. Currently, there's very limited evidence that they're effective at all with young children unless there are serious biological concomitants. The use of psychotropic medications without ongoing behavioral and psychotropic intervention are really strongly contraindicated in preschool children. This is a good time for me to mention that when we look at the use of psychotropics with children, we have to consider that there are very different developmental issues in preschool children, elementary age children, and adolescents, the young adolescents. For the most part, this seems to be associated with the process of apoptosis that we talk about, which is very significant right around the age of starting school, where there's a lot of pruning of neurons and strengthening of certain connections. And this occurs again in early adolescence. So in between, we have a very different brain that should be considered when using psychotropics. There has been a limited amount of research that there is some efficacy of using some medications with children with severe OCD, obsessive compulsive disorder, and extremely disruptive behaviors in a preschool child. But the research indicates that these medications should not be used alone. So you try other methods first, and even once you're using the medication, it's important to continue psychotherapy and behavior management. Now we're going to talk about an integrated psychobiosocial approach to treating the other end of the dysregulation, more flight than fight. You remember, this can be demonstrated in so many ways. School phobia, enuresis, less so encopresis in this case. That's a more aggressive kind of acting out. Clinging, trichotillomania is a common expression of this flight. That's hair pulling, either of the eyebrows or the head. Excoriation, picking at the skin. Stuttering, stammering, tics. But don't forget, it can be shown as the opposite, rages. And another kind of behavior that we really haven't mentioned till now, but I think is quite important, night terrors. Children that wake up not just with a nightmare, but where they really cannot wake up out of an experience that they are being attacked by an animal or a person. And other symptoms that really may be associated with PTSD. What do you do in these cases? Well, I'm sure you have many ideas if you're a child therapist, but let's think about some of the broad categories. Play therapy. This can be of various types, supportive at kind of a la Axline. It could be much more active in an existential way or a gestalt therapy way. You can use toys or puppets or just the relationship. I think with many of these flight reactions, suggestive therapy can be very helpful. I'd like to take a minute to tell you about a technique that I developed. Children have this wonderful imagination, as you know, and if you can access that in their behalf. So I learned hypnosis and then applied it to my work with children. And rather than trying to get them into an actual hypnotic state, I would find out some of their favorite things, toys, colors, whatever their favorites were. And I would create fairy tales for them. And the fairy tales would always include their favorite things and also have underlying messages for calmness, relaxation, overcoming anxiety, or whatever I discovered the trauma to be. And then I'd have children play them at night before they go to bed. I found this very effective, and interestingly, I have had an opportunity to meet people that I treated as children that tell me they still have the fairy tale that I wrote for them some 20 years earlier. And that's probably some pretty good case study evidence that it meant something to them. So we have these more humanistic, creative approaches. We have CBT and systematic desensitization, where you change the thinking. With children, it's just very often helpful to be there with them, move them through the stages of their anxiety, especially if you're trying to work also with the sources of stress that caused the formation of this flight behavior. Within the last number of years, maybe 10, 15 years, We've also discovered that many children enjoy the EMDR. And I have found that rather than asking them to look at my fingers, I'll put puppets on my hands or something that will really attract their attention and have one talking and then the other talking, or opening their mouths as we go through this process of desensitization. If you have other ideas and you could share them with us and other students, ideas where you feel it's been particularly helpful with this population, please let us know. And also, if you have a case that you're particularly concerned about, Dr. Foster and I would welcome you to present it, and we might even be able to make a special presentation to deal with it.
We've talked about this and decided that if you are willing to invest your time and share a particularly difficult case or one that you think would be useful for the other students to learn from, that we are going to scan through the forum and pick a case that seems representative or intriguing, and we'll do a quick video on the case and our formulation and perhaps recommendations about what we might do in a given situation, whether it might be medications that we would favor or a behavioral intervention.
We're really looking forward to that because we feel strongly the more we can use this medium for interaction, the more effective it will be, the more we'll learn from one another. Now you may wonder, it seems like I have just totally avoided classic terminology about diagnoses. And I do think that what I'm talking about here in terms of flight would include the kind of more classic disorders of anxiety, worry, obsessions, compulsions, sadness, depression. I'm just trying to focus more on the psychobiosocial way of looking at it. And if you look at this, I think that there's good reason to do that because a recent government guideline indicates that it is so hard to diagnose these conditions in children, even depression, that it probably is counterproductive to be giving a test and trying to do that unless you have really extensive support and professionals and follow-up. That doesn't mean do not help, but it does mean don't be too quick to give a formal diagnosis. So, what I'm calling flight, which is often more specifically called depression in children, school-age children, has been treated with SSRIs, particularly fluoxetine. It's considered the first-line treatment. It has been used for, probably at this point, 30, 40 years with children. So the long-term efficacy is more known for this drug, this SSRI, or any other drug that might be used for depression in children. The research still suggests that you shouldn't use it alone. The combination of some cognitive behavioral therapy, or I would say other therapy, with the Prozac or the fluoxetine is recommended, strongly recommended in all of these cases. And even also to keep in mind, in the intractable cases, it's really only going to help in about maybe 50% of those children. So another factor to keep in mind, and you can be helpful here, If it's not working, don't keep the child on it. I see a lot of kids that, yes, they have behavioral problems. They are very frightened. And so they're on fluoxetine. There wasn't any measure ahead of time to see if it improved their behavior. The child doesn't feel better, the parents don't feel better, but there seems to be this assumption that they'd be worse without it. So you want to make sure it really is helping the target behaviors. And this leads to the next recommendation. Even if you think it's helping with the child with depression, it's probably best to stop the medication after 6 to 9 months and see how they're doing. Situations may have changed at home. They may have learned new skills where they are operating a lot better. Even if they were doing poorly, you may find they're not doing any more poorly, like I just mentioned to you on the previous slide. But then if you discover this was a child who really profited from the SSRI, you can restart it with more confidence. Now remember though, you've studied about the half-life of medications. Fluoxetine has a very long half-life. So your discontinuation trial is going to have to be at least a month if you're going to really be able to accurately assess the effects of the medication. Now let's talk about what I'm putting under the flight category, but what is often described as childhood anxiety that may be manifest as worry, restlessness, muscle tension, sleep disturbance, compulsive behaviors, obsessional worries such as I'm afraid I'm going to hurt my mom, strange kind of compulsives like I had one little girl that had to always pick up leaves and put them in her pocket. A whole range of different behaviors which we often associate with anxiety. I'm sure you realize, because this is true with adults too, that underneath that we often have a very sensitive temperament, someone that is very anxious to please, that recognizes when others are unhappy with them, perfectionistic, and because of that they may also have a lot of self-doubts, a very negative self-image, a lot of physiological complaints like headaches and stomach aches. The prevalence of these kind of disorders is about 3% of the 11-year-old population. And the retrospective studies in which adults with clear generalized anxiety disorder are interviewed in depth show that most of the time these disorders begin about age 8. And I think that Dr. Foster talked in detail about that in her module on anxiety. The tricky part is that it isn't so clear at age 8, again, that that's what it's going to be when they're adults. Should you use medications for children that exhibit these behaviors, or they may not tell you they're anxious, but you think it's an emerging anxiety disorder? Well, as you can suspect, there's very few controlled studies, but I will tell you there are a number of case studies which suggest tranquilizers are absolutely contraindicated, and yet you see this being done. With children, it can really magnify the problem because they don't have that good of cognitive control anyway, and this really may loosen the controls that they do have so that they exhibit much more severe symptomology. Among the studies that have clear experimental support, CBT is strongly recommended. I think there are many other approaches, like I've mentioned to you, that are more humanistic, that probably haven't had the rigorous study that the CBT has. But there has been this one study, and I give you a reference for it, where they compared CBT and the SSRI sertraline, which does not have an indication for children, I do not think, for childhood anxiety disorders. I would wonder about all the studies since they were clearly diagnosed as anxiety disorders. And they found that both treatments provided some support, but the combination therapy was better. I would wonder how much just the more intense relationship and support had a very important role in these children getting better.
I would wonder if they gave them a combination of the cognitive behavioral therapy and the placebo, whether they would have performed better or shown a decrease in anxiety symptoms as a result.
That is a very good point. Maybe one of you would like to make this. If your study, if you're still working on your doctorate, would be fascinating. So what about post-traumatic stress disorder, which can be the undercurrent trauma that leads a child to withdraw? Well, there are no well-controlled studies that I'm aware of, but researchers would also support, including Straw, that those studies don't exist. There is little evidence that SSRIs are helpful. There's limited evidence that some of these medications that slow the heart rate may somehow be helpful, as well as risperidone and quetiapine, which now has, it's an atypical antipsychotic, which you'll have to check your chart, but I believe it has a FDA approval down to about age 10. No benzodiazepines. Here's someone that said periactin, which is supposed to keep them from throwing up, seemed to help in one case. So CBT, supportive therapies, desensitization are the recommended means of intervention. Now, anxiety disorders in infants, or this withdrawal, may be demonstrated in some ways that are similar to the preschool child and school child, but I just wanted to mention a couple that probably also fall in this category. Regurgitation, and I have seen a number of children that do that. It's just like a little bird. They keep bringing up the food and eating it again. And the failure to thrive, which is, if you've encountered it, it is so distressing to the parents and the therapist to see a child who just gives up and refuses to eat. And what a vicious cycle that makes, because the parents' anxiety goes out the ceiling, where they display that in front of the children, and then that creates more modeling about anxiety. So what do? CBT, supportive therapy, family therapy. In one case where I saw an infant with failure to thrive, I went over to the house for feedings and watched the mother and child and tried to support the two of them. And it took that close a monitoring to be able to break the interaction that was between this child and this mother. You should try in any time with infants and toddlers, try these treatments at least for 3 months before you consider going to medications. And I know that's a hard thing to say because you don't want them to starve to death, but if you can possibly try, it's important because it can take quite a while to extricate all the confusing patterns that may have developed. Now let's talk about post-traumatic stress in these very little children. It's really quite common, and we've discussed this idea that very often, as if you look at it in adult terminology, it might not necessarily be that traumatic, but also these little children, especially in some of the underserved populations you're serving, really have seen horrible things, from earthquakes to a parent being shot. And I know I don't need to tell you about that. So medications are not endorsed by the experts. But you know what? When they do studies, 90% of providers of medication indicate that they are using medication for preschoolers if they have clear evidence of PTSD. So if they come in from an earthquake, it's like they have PTSD, let's put them on an SSRI. So I find this fascinating that it's actually contraindicated, but when there have been any studies, 90% of treating people recommend that these children be on an SSRI. So I'd like in a minute to ask you to pause again and go to our forum. What do you think might be some of the reasons that the expert opinion in prescriber practice differ so radically when it comes to pediatric PTSD? And if you have some awareness, it would really be interesting to know if you see that phenomena happening in your country. So please pause and let us know what you think. I'm going to call a group of disorders mixed fight and flight, but I suppose others might refer to it as bipolar disorder. Many children with a mood lability, withdrawal, and then aggression have been classified as bipolar. I would suggest to you that these could easily be attachment disorders or fight-flight disorders that can be addressed with the appropriate intensive intervention. Now, what makes this complicated is that there probably are some children who develop bipolar disorder, severe by the time they're adolescents, and you look back retrospectively, and sure enough, they could have been analyzed as an attachment disorder or a flight-fight disorder. So you might wonder, is there anything that would help you discriminate more adjustment disorders in children from this more severe diagnosis that leads to the use of medications which can have very severe side effects, and as we know, may work primarily because they're being used as restraints? Well, we do know, and this comes from retrospective studies, that these children often, there's about a year in their early adolescence where all of a sudden you might see a lot of change in behavior, a stubbornness, a bossiness. They were good students and they can't concentrate anymore. May begin to see the beginning of some grandiose thinking, too much energy, new somatic complaints. But at the same time, these rapid fluctuations can also be comorbid with ADHD and disruptive behaviors that become more severe in this age group, the young adolescents, because of peer pressures and what's happening in their communities with drugs, as well as their endocrine changes. So they're just guides. It's not something you can depend upon and say, this is definitely a precursor of a bipolar disorder. There's no consensus if bipolar disorder occurs in preschoolers, but what I have seen is if a practitioner knows there's a history of bipolar in the family and a child at preschool age is exhibiting extreme behaviors, there's something of a likelihood that they might get diagnosed with bipolar disorder. The safest interventions are clearly psychotherapy until we have a clear understanding if indeed these are signs of an emerging bipolar disorder. Some people say that if you see extreme inappropriate elation in the toddler or a kind of hypersexuality, you might want, and a history, family history of bipolar, you might want to keep a watch on it. Generally, medications are not recommended, and the next point I'd like to really stress, no one's recommending combination medications for these young children, although at least in our country, it's not that uncommon to see them on several mood stabilizers and a stimulant, and I don't even want to think about it. What should be used if one is to consider a medication for a possible bipolar disorder in a young child or a school-age child? Risperidone does have an indication now from ages 5 on up. You'll find in the literature a lot of use of aripiprazole, Abilify, off-label. It does have an indication for use for schizophrenia at age 10 and up, but it's being used off-label for bipolar, and the same with quetiapine, Seroquel. Anti-seizure medications have been used kind of in the old way that we talked about, that they work for adults with bipolar disorder. Maybe this is bipolar, maybe it'll work for the child. No systematic studies. This is just a reminder slide that when you use these atypicals, you always have to be watching for serious side effects. And there are some indications that children are more vulnerable to the side effects of atypicals than adults. A particular medication is Zyprexa, which we know is a very effective atypical antipsychotic. It was used a lot with children, and now has a black box warning that it should not be used as the first line because of the tremendous weight gain and hyperlipidemia it causes with children. Let's move now to considering those disorders which we all can think are primarily biologically based. We know there's some biological difficulties that the child has experienced that could, genetic or otherwise, illness that could contribute to their behavioral problems. Here's a list. It's not, it doesn't include all possibilities, but some of the major categories that I think fall under biologically based disorders. I think there's a tendency to quickly medicate these patients, not just the medical condition, but to medicate them with psychotropics early in treatment. I think the philosophy behind that is, well, they have a medical condition, so clearly we should treat their emotional symptoms with medicine. Something of an assumption in there What do you think about that, Dr. Foster?
Honestly, I don't understand it. Why would you, if you have a medical problem that is affecting the functioning of this individual to the extent that it must be some psychological symptom, depression, anxiety, but you know that it is based on their biology, I would imagine that you would try to correct the biological problem and then use behavioral techniques if they've learned some maladaptive way based on having the symptoms. And then only much later would you consider using a medication, I'm assuming, like in the case of schizophrenia. But to me, it sounds very much like that 90% you talked about earlier, treating PTSD with medication when in fact it's not even indicated.
Well, we don't have the same numbers here, but it certainly is a strong trend. Keep in mind, too, that some of these disorders cannot be fixed. It could be a genetic disorder, it could be mental retardation with all sorts of ramifications. And so that leads people to say, well, I know it's genetic, so let's treat it biologically. But I agree that doesn't necessarily follow. And we're going to see some research which supports that that doesn't follow. So let's look at autism spectrum disorders. To receive this diagnosis, the symptoms must be present before age 3. And psychotropics have been used quite a bit with this population, particularly the atypicals, risperidone, to manage the aggressive behavior. Really, what we're talking about here in the autism spectrum disorders are some specific skills that could be ameliorated with sophisticated interpersonal help, social communication skills, ways of desensitizing, a variety of techniques that could be tried before assuming this is a medical problem that should be treated with medication. What should we do? Well, this is what the National Institutes of Health recommends. If you suspect autism, start very early, because the more healthy the environment, the more stimulation, the better the chance that the interventions will be possible. Whereas maybe 15 years ago, it was often thought that autism was so genetic, it was immutable, you couldn't make any difference, all you could do is treat the symptoms with some medication. We now have increasing research that with early intervention, you can seem to facilitate the child moving forward so they have a less severe form of autism. So behavioral management, language training, occupational therapy are very, very important. And it is important to understand that often these children have associated medical conditions. So treating the medical conditions with medication or diet certainly makes sense. Risperidone obtained an FDA approval for treating irritability in autistic children in 2007. But even with that indication, please keep in mind the serious side effects that we have discussed. I thought this research was very interesting. There actually is research to show that SSRIs do not help people with autistic spectrum disorders. However, I imagine that's the first go-to medicine by a lot of practitioners. Why? Well, the side effects are less worrisome, and I think that people want to do something, so they're thinking it'll help. But in fact, they're likely to increase energy, and that can increase hyperactivating behaviors. So the picking, the hitting their heads, the rocking, the difficulty sleeping, and it can easily be thought that their disorder is getting worse. And thank goodness we have this SSRI on board, because without it, they'd be even worse. So again, you know, a trial off and on is often called for, but you need to know that SSRIs have not been shown to be effective with autistic disorders and have many adverse effects. Now, Dr. Foster raised the point, like, this seems so contraindicated to put them on all of these medications, these autistic children. Why is that happening? I mentioned the seriousness of the symptoms, but I also want to mention something I'm not too proud of, which was a movement among psychologists with a child therapist, Bruno Bettelheim, as the leader of that movement, who coined the term schizophrenic mothers for the mothers of psychotic and autistic children. He blamed the mothers completely and claimed that if they had a loving environment, they would be just fine. And so he had a center that he set up and claimed to be fixing all these kids with these very serious symptoms. And years after his death, it was discovered that that data was made up. It's awful. So he not only made up his data, but he coined this terribly destructive term, schizophrenic mother, which I think pushed people away from psychological interventions to biology and psychiatrists, someone that would understand that this disorder was too big for them to handle and wouldn't blame them. So please keep in mind, though we don't want to use medications that have no medical indication, we don't want to make these parents feel like it's their fault either, because managing these children can be so difficult. I know sometimes in play therapy with them, I would find myself being very impatient, and a very erratic autistic child that I saw. First of all, he was playing with the bugs in the corner of the room, and then he was tearing off all the toys from the shelf. And all I could say to myself is, how does the parent handle this 24/7? So we need to have a lot of empathy for these parents and make sure they don't interpret our interventions as criticizing what they're doing. Now we're going to talk about the treatment of attention deficit hyperactivity disorder, which many authorities believe has a physiological basis. What is the purported theory about the cause of ADHD? It is hypothesized, and there's some research, that these children have an alteration in the dopamine activity in the prefrontal cortex. And because they're not getting enough useful dopamine, they are more distractible, impulsive, hyperactive, and that stimulants will augment the amount of dopamine they're receiving. There's also the belief that they are lacking in dopamine in the nucleus accumbens. That has to do with pleasure and reward. So some people say, why does he keep doing that when it obviously leads to disaster? I just don't understand it. Well, if they aren't able to process their behavior, and on top of it, they don't have the normal punishment and reward response, possibly that's why they continue doing these behaviors that seem like they would get the idea. Even the puppy dog in the house gets the idea. But if in fact the stimulants are increasing the dopamine in the nucleus accumbens, this leads to another question. Since that is the center for pleasure and reward, and that's the center that gets stimulated when people are using street drugs, are we, if we treat these children, making them more likely to become drug addicts when they're older? So what should you do with children that you suspect have attention deficit hyperactivity disorder before you consider medication? Well, first line is behavioral management, and that involves teaching the parents and the teachers how to work with this child. These children often profit from special accommodations. For example, some experts have recommended letting these children sit on one of those big blown up air balls so they can bounce, so that they can increase their own dopamine activity. They do better if the work sessions are broken up into very small sections. In fact, there's a psychologist that has devoted his life to studying ADHD, Russell Barkley, and he established an experimental classroom with children with very severe ADHD, and he was able to get them to perform without putting them on any medication. But now it was a highly expensive, high intervention, high activity, high stimulus environment. But the more we can approximate that, the better these children will do. It's very important with these children to avoid criticism and discouraging them. But boy, that's a challenge. We need to work with the families to know how important that is. They can be patient once, twice, 5 times, but the 10th time they take a glass into the shower and break it, which I had a child do, I don't understand. I told you 10 times not to take it in there. That's dangerous. You could have killed yourself. You know, on and on. It's understandable. But these kids are already quite confused, not processing matters well, and before you know it, we will create a secondary depression or other problem in them. Russell Barkley made a comment one time, which I loved. He said, an ADHD child will do something right one day, and his teachers and parents hold it against him for the rest of his life. And I thought that was so cute because under ideal conditions, maybe they're feeling good, they got enough sleep, it's a stimulant, they do well. And then you say, you managed to be so well behaved in school today, there's no excuse for your misbehaving tomorrow. And not recognizing the challenges that they're up against. So what are the medications recommended for the treatment of attention deficit disorder? The classical FDA-approved medications are derivatives of central nervous system stimulants, dextroamphetamine and methylphenidate. There are also several medications on the market that are not stimulants, particularly Strattera. It first came on the market as a tricyclic antidepressant and wasn't very effective for managing depression, but serendipitously seemed to have some effect in increasing attention. Also used are different forms of the blood pressure medicines guanfacine and clonidine. Now, why exactly these seem to be working? I don't really think they're affecting the dopamine, but they are slowing the impulsivity and allowing these children to sleep better. So we do see a number of children that are on medications from each one of these classes. These are used so commonly, let me just review them a little bit for you. Methylphenidate. It only lasts about 8 hours. So if a child is on methylphenidate in the generic, it's going to require medication several times during the day. They have to be taken out of the classroom and given medication by the nurse, which clearly separates them and may in itself cause some trouble. So everybody was really pleased when Concerta came on the market because it is a long-acting form and lasts up to 12 hours. Even so, many providers that were using the medications and families feel like that's not long enough because it gets them through school, but they can't get their homework done. So they would be given something like Concerta or Metadate CD or one of the other long-acting drugs, and then a dose of methylphenidate like Ritalin when they come home from school. We also have a group of medications that are dextroamphetamine with different names. The primary one is Adderall. And really, this goes right back to the original fellow we discussed who was treating what he called minimal brain dysfunction with benzodrine, same drug. A newer medication that's come on the market that's become very popular because of its tolerability and because it lasts longer than all these other medications is Vyvanse. It lasts about 14 hours or most of a child's waking time. So you see all these different names, and now you'll understand probably the main difference is in the half-life. So we've talked about a lot of common sense information, but also some fairly technical information. And I found on YouTube this short clip about Adderall that I thought might help bring home the point.
It can make you happy, suppress your appetite, reduce fatigue, increase your attention span, and is used to treat narcolepsy, depression, and ADHD. What magical substance does all this? Adderall. Over 25 million people worldwide use amphetamine, which is the active ingredient in Adderall. Amphetamine has been around since the 1800s and has a pretty neat history. First synthesized in 1887 by Romanian chemist Lazar Adelano, amphetamine appeared on the market in 1933 under the name Benzodrine, or Bennies for short. In 1943, the U.S. Army began issuing pep pills to fight battle fatigue and boost morale. These pep pills were pure amphetamine, which is a stimulant. By the end of World War II, American and British troops had shipped an estimated 150 million of these pills. Japanese and German troops also used these pep pills, and Hitler would get daily injections of amphetamine. American troops continued using amphetamine well into the Korean and Vietnam Wars, but stopped once the drug was no longer sold over the counter in 1956. Because, unrestricted access to pure amphetamine is probably not a good idea. Today, amphetamine is used in low doses primarily to treat... Wait, what? Oh, right. used to treat ADHD. The majority of ADHD drugs stimulate the central nervous system. You'd think it wouldn't make sense to treat hyperactivity and lack of focus by adding stimulation, but we'll let neuroscience expert Dr. Ryan Davison explain.
People with ADHD tend to have lower levels of dopamine, a key chemical in the brain's reward center. This lack of dopamine means people with ADHD are constantly seeking stimulation. Amphetamines stimulate the release of dopamine and other neurotransmitters in the brain, so those minor distractions don't cause you to lose focus.
Nerve cells and neurotransmitters act like they're at a middle school dance. Neurotransmitters like dopamine are on one side of the gym and receptor cells sit on the other. Amphetamine starts the party by pushing dopamine out into the dance floor, where they then partner up with the receptors. Amphetamine also keeps dopamine on the dance floor, leaving more for the receptors to catch. So before we go, here's Dr. Davison with another fun fact that shows why little tweaks in structure can make for big changes.
Here's what a molecule of amphetamine looks like. This little guy is a group of a carbon and 3 hydrogen atoms, also called a methyl group. If you add one more methyl group onto the end of an amphetamine molecule, it turns into its much more dangerous cousin, methamphetamine. These 4 little atoms can turn you from a studious citizen into a total tweaker.
So while you're still focused, don't forget to like, share, and subscribe. And if you enjoyed this, be sure to check out some of our other videos on how caffeine works and learn all about marijuana. Have an idea or suggestion for us? Let us know in the comments or hit us up on Facebook or Twitter. And hey, thanks for watching.
These drugs are not freebies. They will increase attention. They'll do that in people that don't have ADHD because they increase dopamine in the prefrontal cortex. But they have very common side effects: weight loss, nervousness, sleep disorders, stomach upset, tremors, tics, anxiety. Sometimes you see a child that's been on a stimulant for quite a while that even looks abnormally thin. And I think this causes problems in their relationships with others. It's kind of a funny looking thin because it's medically induced. So we need to make sure that the benefits outweigh the side effects.
I have a question.
Yes.
Should we look for the irritability that we typically see with adults on stimulants when we treat children with them?
I think that's a great addition. That shows how all the experience that you have with adults really has some relevance here. So yes, let's certainly consider irritability too as a possible side effect. Is it overcome? Is there a balance because they're concentrating so much better or not? The irritability question is an interesting one because some parents will say that they think the stimulant has helped them concentrate at school so well that then when they come home, they're twice as irritable. They like let it all out. But it's certainly something that we need to look at. Now, earlier on, I posed the question, since these drugs affect the reward center, do they cause later use of illicit drugs? This issue has been studied to quite a bit, and overall, the results suggest that no, it does not lead to a higher use of illicit drugs than a control sample of these ADHD children who are not on stimulants. Now, why is that? What I think and what I think is mentioned in the literature is that if this is the best way that people have been able to get this child to concentrate, to learn, to get positive reinforcement, then they're much less likely to feel the need to use illicit drugs to deal with all the other psychosocial unhappiness in their lives. So when you match them against the kids that haven't been on stimulants, it doesn't increase the frequency. I am not aware, and if any of our listeners are, if there's been a study where they've said somehow also had a third group where they looked at ADHD kids with and without stimulants and compared it to kids similar in every other way that don't have ADHD and drug use. So this is just about the use of stimulants with this population. Whether or not they have a higher, I think they do have a somewhat higher use of illicit drugs than other children, but then that may be because of the one group that is not using the stimulants. There are more serious side effects. They're not too common, but we need to watch for them. Well, actually, increase in blood pressure can be pretty common if the child is obese or already has high blood pressure. My experience has been if their blood pressure is normal, it doesn't seem to change it. But if they already have some problems in that area, you really need to watch it carefully. There have been, and by 2006, 25 reports of sudden death from heart problems. Now, what this research is saying is that these children had previous heart conditions that hadn't been identified. And so when you added the stimulant, there was a certain percent that had a sudden death, which really leads to the recommendation, I believe, of the importance of getting an EKG before considering the use of stimulants with children. For some children, this is just way too activating, and they end up having more hallucinatory experiences. There has also been quite a bit of controversy about whether or not it stunts growth. And really the data isn't that clear. For a while they're saying the data is clear. It can decrease height by up to 1 inch. And a study I read recently said that's not true. So it's a little iffy about this. But if you have a really short child, it's certainly a factor that one might want to consider. Is the use of stimulant drugs out of control in the United States? Well, many psychiatrists stress that the side effects are rare and they're some of the safest medications and they really help children. Whereas other behavioral therapists claim you can have equally effective results with behavioral interventions. Now, there's a very complicated study called the Multimodal Treatment of Attention Deficit Hyperactivity Disorders by the National Institute of Mental Health that caused many, many hundreds of thousands of dollars. And at the end, and they followed these children for a number of years, the results were really quite equivocal. In the short run, the stimulants seemed more effective than what they considered the control, which was just treatment as usual. Go wherever you want, get whatever you want. In about a year, there was kind of a shift where, well, it looked like both approaches were about equally effective. And after 4 years, the researchers claimed that it looked like the social support, all sorts of different interventions worked better than the medication. To me, there's a real limitation to this study in that even though they went through 4 years, they didn't manage the children for 4 years. You know, everybody thought it was wonderful because it was a study done out in the field. But after they finished the study in 9 months, they let people do whatever they wanted. So you had children in the therapy group now taking medication. And you had children that were in the medication group no longer taking medication. So I'd be interested if you read this study. From my reading, I'm not sure that it tells us much of anything for all that money, other than both approaches seem to work in some cases with some children. Others, such as William Carlston says, don't you think these are innocent? They leave their signature on the brain. They affect these children, and they're in these crucial developmental stages. Please keep that in mind. The final category we're going to look at today, which I have classified under basically biologically based disorders, is schizophrenia and other psychoses. Now, you might think, well, that should be pretty easy to diagnose, particularly if a parent is schizophrenic, but in reality, that's not true. You could have a child with a schizophrenic parent that is learning some kind of inappropriate behaviors. On top of that, children have this wonderful creative ability, and the bounds between reality and non-reality are not so clear. What if they have a playmate that's not real? What if they think the animals are talking to them? Now, if you're an adult, that's a sign of hallucinations and delusions. But the line at which a child has, you can really call it a hallucination or a delusion, is really difficult to determine in children. On top of that, sometimes children with other disorders, like the child I told you about, that who just had an attachment disorder, was overly attached to his mother, they can be so extreme that people think, well, there must be a psychosis here. And they actually kind of look for it to see if they've ever thought something that's a little bizarre. So the diagnosis is quite difficult.
I really appreciate the fact that you pointed out that childhood schizophrenia may not be schizophrenia at all. I saw a woman just the other day who witnessed her husband die. He was already dead when she discovered him on the couch, and she hadn't realized that her 18-month-old son was with her, right behind her, when she discovered the body. And she said that he's 8 years old now, but since that time, not only does he remember, which I think is amazing at 18 months, not only does he remember discovering the body, but she said that he tells her that his daddy is still reading to him at nighttime, that he still speaks to his father, and the thinking is that he is psychotic.
Wow.
And in my mind, I'm questioning whether he could have a post-traumatic stress disorder. I'm thinking about severe grief reaction, albeit it's been years, but he's never been treated. So this just has been layering year upon year, potentially making this child look more and more psychotic. But he's never, like you said, the core issue has never been addressed with this particular child.
What an interesting example.
And would you want to put a child like this on risperidone and take a chance, in other words, of putting him on an antipsychotic for this schizophrenic hallucinatory behavior, when in fact this child, I am assuming, is still grieving the loss of his father?
And did you think that the mother had PTSD?
Oh, absolutely. Okay. The mother had PTSD. She had a picture of her husband, I shouldn't say a picture, a tattoo of her husband on this part of her breast. She had his name written on the middle of her chest, and over here she had a blended tattoo with him and her. And during the session, she cried as if it had happened just the other day.
This is getting more interesting. So now, I think it's going to be a good example of everything we've been studying so far. Did she have other disorders too, do you think?
Yes.
What else?
She had anxiety disorder, she had a depressive disorder, and she was borderline. She had a lot of self-mutilation, history of sexual abuse.
Okay.
I could go on, obviously.
Let's go with that he remembers 18 months old, his father dying. I would doubt it, but with her PTSD and all this stuff over her body, she has kept the fear alive, the trauma alive. I'm not saying he wasn't traumatized. I don't think an 18-month-old can really visually remember. He can have a feeling. But the fact that she is still in this protracted grief re-stimulates it. On top of that, he sounds like the perfect example of the prisoners of childhood. A little kid that's learning he has to take care of his mother. So she misses the father. If he holds on to the father and he tells her about the father all the time, he's helping her. So, I love that example because it's like right on the spot, the kind of complexities we deal with and how wrong it is to just assume a diagnosis from a symptom when you're dealing with children. I want to remind you that that doesn't mean that there aren't cases where people have schizophrenia and you can then look back in a retrospective study and see that it started when they were age 5. And that makes everybody sad and wish that they had taken more active intervention at those ages if you later discover this wasn't just a wild imagination. So we want to watch these children, but that doesn't mean we should jump to medication. I'm going to give you a chance to read this study here. I won't go through all the details, but it just confirms of all these children that were put in the hospital with the diagnosis of psychosis, schizophrenia, how few of them really came out of the hospital with that same diagnosis. And we don't have any way of determining this with physiological tests, although we do think it's a genetic disorder, though there seems to be some promise with magnetic resonance imaging. So what do we do for these children with these severe problems if we're not going to jump to the use of medications? Well, I love Dr. Foster's example because, first of all, you want to be cautious. It may not be psychosis. There's a lot you can do. So you want to critically analyze the case. Play therapy is helpful. And even if this turns out to be a child that you later say, boy, that was a precursor of a severe psychotic disorder, a positive sign in the research is that if you create a calm environment at home and in school, and you minimize stress with children with a great deal of vulnerability, there's increasing research that suggests you may be able to prevent the florid development of the symptomology. Because remember, it usually is a combination of genetics and stress that leads to psychological disorders. What if everything's been tried? And again, we have a child that is really miserable, like the little boy I told you that felt like alligators were fighting inside of him, and he was very vivid about it. What should you do? What kind of medication could you use? Well, a lot of medications are being used that are the older antipsychotics. I just want to remind you that there really haven't been adequate controlled studies, even though they have approval. Risperidone, quetiapine seem to be the ones that are most effective with these children. Mainly, consider the psychotropics for managing destructive behavior or anguish that you just can't seem to help the child relieve in other ways. Woo! That's a lot. Are there some common themes we can glean from all of this? I'd like to think so. The first one is, I don't need to tell you now, we need more studies. That is clear. We've got to keep in mind, do no harm. Look at the risk-benefit of using these drugs with medications. Some of you might be interested in learning more about the ways that we're looking at the risk-benefit ratio in terms of the number needed to treat versus the number that causes harm. We need to be aware that there is this strong bias in the pharmaceutical industry and a curious lack of documentation about the drugs that are used with our children. So now, Dr. Foster, you weren't sure you should sit through this presentation, and you knew you weren't supportive of medication for children. What do you think?
I think that short of the most extreme cases, I am still against using medications with children. And I feel like I am a very soft voice in a loud crowd of very powerful people who can promote these drugs, the pharmaceutical companies, and the psychiatrists or physicians and PhDs who are paid a lot of money to find positive findings with these drugs. One, because I see that placebo has such a significant impact, and I'd rather give them a sugar pill than to give them something that, for example, risperidone and the use of the first generation antipsychotics over time, we know, produce something called tardive dyskinesia. Are you going to continue this child on an antipsychotic for several years, every year accruing a greater and greater risk for producing tardive dyskinesia in these very young children? Are they going to live the rest of their lives with tics and snake-like movements that they cannot control? How much better is that going to make their lives in the end? Again, I know it's a somewhat radical approach, and that's why I've really never chosen to treat children, because I think my heart is too soft, and I will always probably be looking for an alternative approach. Interestingly enough, a ranch that I owned when I lived in North Carolina was bought by a charitable organization, and they do equine therapy, meaning they use horses with children who suffer from autism. And so I would just love to see more of those kinds of interventions, but I know that there's not big money going into equine therapy as opposed to the drugs that are manufactured and patents are developed on.
Okay, before closing, let me just share the case of the Hulk with you. Because for the most part, I agree with Dr. Foster. But despite all the skills that I think I have, I'm so glad I had risperidone with this little boy. He was born, right after birth, he had a stroke. He had left hemisphere damage from the stroke, and the right side of his body was weakened. He only had one kidney. We tried everything with this youngster, and he had wonderful parents. And we worked with the schools. The schools were wonderful. He was a sweet child until about age 5. And then as the pressure in his life increased and he couldn't do things, he would just get so frustrated. And periodically, he would go wild. He would tell me he felt, have you seen the cartoon, the Hulk? He's this man that gets mad, and when he gets mad, he turns into this monster. He called himself the Hulk. And he said, I don't want to feel that way. I hate to feel that way. I feel like I'm a monster. And he couldn't control it. So he was miserable, and he had no friends, and he was beginning to threaten his brother. I mean, we tried supportive therapy, family therapy. We were just about to try putting him in his bedroom, having a screen door that we locked so we knew he was safe, but he wouldn't stay in timeout when he got these kind of rages. It was just something else. 0.5 milligrams of Risperdal made a huge difference. He really was able to be the sweet little kid he was when he wasn't the Hulk. So when the family came back to see me when he was in high school, they did so because the person that was prescribing the 0.5 Risperdal was no longer available, and I was now a prescribing psychologist. So his behavior was so out of control at that time, threatening, hurting his little brother. Not all the time. It was still the Hulk that came out at times. His father couldn't handle it anymore. The police were called 3 or 4 times. He said this was creating trauma with his father. I remember one time he looked at me and said, "What kind of father calls the police on his child?" So, you know, the problems are compounding in compounding. Well, remember I told you that adolescents are fast metabolizers. So the main intervention that I made at that point was to raise his risperidone from 0.5 to 1 milligram. And he was able to gain much more control over his behavior. Now, we didn't just do that in isolation, and I do worry about the long-term effects, but in my book, the cost-benefit was worth it. So, let me summarize this presentation for you today. If you look at all the research, Skinner wasn't right. Children are not blank slates. They're filled with emotions, thoughts, creativity. We need to know who they are and how the environment is affecting them. But they're also not little adults. They play by different rules, their own rules. And preschool rules, elementary rules, adolescent rules, all of those are very different too. Because of the way they respond in an overall physiological reaction to so many different stressors, it's such a challenge to come up with the appropriate diagnosis. And we've seen from the research that medication is very seldom the first-line approach. There's clearly no data to support the use of multiple medications with this population. So consistent with our biosocial model, psychobiosocial model, we want to understand the child's background, medical history. We want to really know that child and how she relates to her family and society in order to be effective in our care. Dr. Foster, I want to thank you for those excellent questions and keeping me on my toes. And I particularly like that case, which seemed to me to bring so many of these principles home.
Actually, now that you responded to my concern about the child, it really pointed out to me just how much of an impact that mom was having on her son. And because it's so easy to listen to it from her eyes and perspective. So when she says, oh, he's having all these troubles and I don't know what to do about it, and listing them out, it's easy to turn the focus to the child and think, oh boy, something really bad must be going on with that child. Maybe he is premorbid schizophrenia. But you reminded me to turn the focus back on mom and see what kind of impact her psychological functioning was having on the child.
And he was really in distress too, but we can't look at him separate from his family, his school, and his larger environment. Thus, the psychobiosocial model of care. Thank you.